Thank you.
Thank you.
Can you guys hear me? Excellent. Perfect. Thank you, Griffin. This isn't so bad. You guys are nice. Okay, I can do this. So first off, thank you, Stephanie. That was really, really interesting. I don't know where she went. Really interesting, though. And thank you, everyone, for joining me for day 2. I'm Laura McQuillan, and I'm from Edmonton. I did my practicum with the First Nations Inuit Health Branch. And for time's sake, and in line with government values, I'll make sure I only refer to it in its fancy code talk as FNIB, or FNIB Alberta, for the rest of the presentation. So the mandate at FNIB is based on 3 points: to ensure the availability of or access to health services for First Nations and Inuit communities in Alberta, to assist First Nations communities address health barriers, disease threats, and attain health levels comparable to that of other Canadians, and to build strong partnerships with First Nation and Inuit to improve the health system. So at FNIB, I was working with the Strategic Health Intelligence and Partnership branch, and it's the branch that's responsible for policy and health surveillance needs. And so I worked specifically with a group of epidemiologists and had the opportunity to familiarize myself with data collection and reporting at the branch. And it's from this data collection and reporting that my project came to be. Initially a little bit of a fishing expedition, but it eventually shaped into a scoping literature review with the goal of further disaggregating data used at FNIB Alberta. So reason being is current data reporting does a really good job at highlighting health inequities between First Nations and non-First Nations communities. However, it doesn't do a great job of highlighting health inequities among First Nations communities. And examining variations among communities provides a base from which decision makers can create targeted health interventions. So this tailored and targeted approach ensures that communities receive optimal health programming and improves health status and health outcomes. So this developed into the research question: moving beyond treaty, age, and sex, what potential indicators are available to aid in the examination of health inequities and reduction of in the examination and reduction of health inequities at a community level in Alberta. So before diving into my project, we'll just go over a couple key public health housekeeping rules, we'll say. So health inequality versus health inequities. They can be very confusing. They sound very similar. They're different, though. So World Health Organization defines a health inequality as the difference in health status or the distribution of health determinants between different populations. Health inequalities typically stem from biological variation or personal free choice. For example, an individual who chooses to mountain bike makes the choice of the increased health risks associated with that. In contrast, a health inequity is defined as the difference in status or the distribution of health resources between different populations arising from the social conditions in which people are born, grow, live, work, age. Health inequities are of major concern and are a key focus of the public health community. They're unfair, unnecessary, and avoidable. So research over the years has illustrated the gap in health status and health inequities between Alberta's First Nations and non-First Nations. But furthermore, just as culture and tradition vary by First Nation communities, so do health status and health inequities. So health inequities in Alberta. Like I've said, reporting has been very thorough between First Nations and non-First Nations, but many health inequities present among Alberta's First Nations stem from the social determinants of health. Aboriginal health inequities generally arise from socio-economic factors in combination with cultural and historical specific factors. So just to illustrate some of these points, 3 in 4 First Nations adults are overweight, obese, or morbidly obese compared to 1 in 2 First Nations adults in Alberta. Okay. First Nations are 4 times more likely to report living with diabetes than non-First Nations in Canada, and First Nations are at a significantly higher risk of living in overcrowded housing. So what's the importance of data and reporting? And Dr. Stanwyck spoke about this today. The importance of evidence-based and understanding is that numbers and figures collected by data tell stories and can illustrate the health status of a community. Health data is a key tool for public health practitioners. Identifying factors illustrating differences and changes in health status over time are all critical factors for the delivery of health services and program planning. So providing accurate community-level health data allows for decision makers to prioritize health needs. So moving forward onto my project, what did it take to be included in my very fancy literature review? The inclusion method is that research needed to focus on health inequities or health status between Aboriginal and non-Aboriginal populations or within among Aboriginal populations. Publication and research origin was limited to Canada, Australia, New Zealand, and United States, and I chose that because of the historical similarities of Indigenous peoples in these communities. English language, publication between 2000 and 2015, and academic journals and government reports. So my primary methods were electronic databases. Because of the breadth of the research question, I used a wide range of search terms just to give you some examples, but there were many more that were also used. And reference reviewing was very helpful over the course of the research project in terms of examining what's out there. So for my results, the evidence supported 8 indicators which helped identify, measure, or address health inequities among First Nations communities. That being said, just because the indicator may have been useful doesn't mean the data was available to support reporting on that indicator. Oops, it went forward. Oh no, I reversed everything. Sorry. Take one step back. Initially, my research revealed 74 journal articles, which after a title and abstract reviewing, limited it to 35. After reading through the articles and the research topic, 21 were included, along with 7 that were used as gray literature or supplementary information. Now what I just said before. And so going into the legend, green meant data is currently available to begin reporting. Yellow, does that look like yellow? Yeah, yellow meant that although it was available, it may have required further collaboration with other stakeholders, be it Healthcare Statistics Canada or Alberta First Nations Information Government Center. And red meant great indicator, but data wasn't available to start reporting on. So I'm going to go briefly through my indicators. If you'd like it in more detail, I'm more than happy to send you the report. Initially, household income and income quintiles were identified as data is currently available within FNIB Alberta. We're currently able to report, and these indicators effectively highlight health inequities among First Nations communities. So there's 4 points that required a little bit more collaboration. Geography and culture and colonization referred to Western acculturation or the adherence to traditional practices. Language refers to the protective nature. Research revealed that traditional language knowledge seemed to have a protective nature against certain chronic health conditions. Health service accessibility and stress, all with the yellow the yellow data collection. And then home ownership and health literacy, both data is not able to report on these indicators. However, they definitely need to remain in the forefront of FNIB Alberta's mind moving forward in terms of identifying and tackling health inequities among First Nations communities. So in conclusion, the limitations and the strengths. I found that number 1 and 2, so the limited research time and the broad research topic kind of worked together in the sense that there was a lot of information in the limited time with which to scan through all that information, but also a limited Aboriginal specific research and the availability of Aboriginal specific data seemed to really move to the forefront the more research I looked into. And that, in explaining that, it's that lots of data seem to be available on the comparison between First Nations and non-First Nations, but First Nations specific really was lacking, and that was a really big flag to me in terms of moving forward. This is something that we need to focus on as the research community. And for strengths, this is a really great base moving forward for FNIB Alberta in terms of continuing to ensure that literature scans and literature reviews are being done to make sure that we're using up-to-date indicators for addressing these health issues to improve First Nations health status. The flexibility of the search terms is really great, and then the reproducibility. So congratulations to everyone who's already presented and to those of you who are about to. And thank you to everyone, Betty for the beginning, Victoria and Catherine for your support throughout it, as well as all the faculty that I'm sure got emails throughout a million times. And my friends and family at home watching, and my dad who's cheering for himself right now there in the back, and my mom and my brother. So thank you guys all for listening.
Thank you so much, Laura. Good job. So, questions, comments, questions? Yeah. Dr.
Richard Stanwyck, I had the opportunity before you. I do have to say I was probably as stressed as the rest of you addressing this august group. Excellent work, and again, I think just underscoring the importance of the evidentiary approach in terms of shaping policy. My one question is, I hope you will be sharing this with the First Nations Health Authority, because I can assure you that the medical health officers that, under the leadership of Evan Adams, would probably find this of good interest in the starting point for collecting similar information in British Columbia, where we have the advantage of First Nations now being at least partially responsible for their health. So well done, and I think a document that is worthy of sharing.
Excellent, thank you. I'll pass it on to my supervisor as well. And something just to comment, to tack onto that, was I was really surprised with so many times I found myself asking, like, where is this? I had the whole research in my mind and I was looking at, but where is it on paper? And I couldn't find it, and it's because it doesn't exist yet. And it just seemed like obvious questions to me that we should have the answers to, but they don't seem to be there. And it was really surprising that there wasn't that kind of data and research out there already. So thank you for the question, comment.
Hi, great presentation and excellent topic. I had a question about why home ownership was identified as an indicator versus quality housing.
Well, home ownership, it's an interesting subject within First Nations community, because the traditional sense of home ownership isn't the same when people, or when First Nations live within King Reserve communities. There's not the traditional sense of I own this house. However, there was research that highlighted the devolution of power in terms of upkeep or maintenance of the home, which sometimes falls to the band and council. When individuals had more ownership and responsibilities, there seemed to have higher levels of health protection in terms of their overall health status, which was typically measured by chronic disease rates, and diabetes specifically seemed to be lower when they had that higher sense of ownership and that higher sense of responsibility in terms of upkeep, rather than some band councils, which home upkeep, like we saw with the stat, doesn't really seem to stay on track, and overcrowding and housing quality becomes an issue. So hope that answers the question.
Yes. Dr. Lobe, yes.
Thanks, Laura. That was great. I'm just curious, did anybody steer you in the direction of the First Nations Regional Health Survey?
Yes.
Okay, so you did get some stats from that.
Yeah, and that's also, when I referred to the yellow points in collaboration, there is amazing research that's being done, and that's under the Alberta First Nations Information Governance Center. Right. They produced the Regional Health Survey. And they actually have, we were not totally sure what level in terms of FNIB, what level is it community-based, is it by treaty area, but that's what I meant by collaboration, is they have really great data that's being collected. We're just, or personally, I'm just not sure what level or to what extent it's being, so that's why it was reported on, like stress level specifically was highly reported on as an overall statistic for Alberta, but we're just not sure how much further it goes and how much more collaboration we need to come together and collaborate with our data to really present the whole picture like that.
Yeah, you should be able to find out how many of the First Nations in Alberta actually participated.
Yeah, there is some of that.
Fairly high number of them.
So, okay, thank you.
Okay, I guess we're
Wait, is that it? No more hands went up, so.